slogging through the trenches as healthcare heroes. Well, you know, we were all considered healthcare heroes until this vaccine mandate. And now, just because I don't want something foreign and experimental in my body, people are calling me an anti-vaxxer and refusing to come to my clinic and challenging my license. Anyway, that's I'm just joshing. How are you, Dr. K? How are things going?
Oh, I'm chilling, man. I'm so excited. My belly is about to burst thinking about our topic today of approach to abdominal pain.
Yeah, I have butterflies too. This has been I've been thinking about this all week. Absolutely. This is exciting. So what a high yield topic. And I think we'll be taking a bird's eye view, perhaps with an anatomical breakdown approach to abdominal pain. So useful in many different settings, primary care, and high yield for your exams as well. Does anyone want to kick it off? Like, should we just get right into things here? Hit the ground running? What case presentation? Gentleman comes into your urgent care. He's just holding he's belly aching. He's belly aching about his belly ache. He says, "Doc, my belly has just been aching. I don't know what to do." So you lay him down. He's obese. He has a large penis, and you're looking at his abdomen. How might we start with this patient? Maybe starting with like a history for his presentation.
Yeah, sure. So the differential diagnoses for abdominal pain, the differential is going to be huge. I guess it's important to consider all of the variety of disease processes that could be contributing to this presentation. It could be inflammatory, it could be perforation, obstruction, ischemia, hemorrhage. It could be all sorts of different systems. It could be GI, urological, vascular. So we're going to have to take a very thorough history. We can't really beat the classics. So taking a thorough pain history is a good start. So people have all sorts of different acronyms, whatever. The main focus should be, where is the pain? So the site, the onset, when did it start? What's the character of the pain? Does it radiate anywhere? Does anything make it better? Does anything make it worse? Does it come and go? And how severe is this pain? Because we're certainly going to take it even more seriously if the pain is 11 out of 10 and they've never experienced pain like this before.
Absolutely.
Yeah.
I agree. I think that old carts or whatever mnemonic you're going to use, but that old carts like history, comprehensive history, is especially useful for abdo pain, chest pain, which will really give you, enable you to sort of narrow based on anatomy and based on systems, your differential. So maybe we'll have this gentleman be a useful sort of standardized patient here. So we're looking at his abdomen. He's sweating. He's a little bit hypotensive. He's a little bit tacky. He reports being febrile, but he has no fever at present. He's mentating fine. He's not vomiting at bedside, but he is complaining of some nausea as well. He's in his 30s. He does have a history of type 1 diabetes, but he's complaining of pain in his lower quadrants. Any further history you might want from him to tease out or to narrow our differential?
Yeah, I guess I would be very curious about whether he's ever had this before, whether it's sudden onset or has been like slowly worsening, whether it has been like an oscillating course, or whether it's just been getting progressively worse. aggravating and alleviating factors are very important. Did it come on after food? Was it worse a couple hours after food? Was it associated with like straining on the toilet, improved or worsening with stooling? And then it's also important never to forget your just general review of systems as well. Does the person have a fever, chills? Are they unwell? Do they have nausea and vomiting? If they have stooled, is there anything in it, such as is there mucus in the stool? Is there blood in the stool? How firm and formed is the stool, as well as how often are they stooling? All of those are very important. And then you also have to remember that not only is it you're looking at GI in the abdomen, but you're also looking at a bunch of other things depending on where the pain is. And specifically in the lower quadrants in a male, you're thinking of the renal system, so kidneys and bladder, ureter, urethra. So you should do screening questions for that, as well as GU. So testicular pain.
Yeah, useful to highlight that like off the top, particularly, going into your emerge rotations. Any menstruating female is pregnant until proven otherwise. And that has implications in terms of things like imaging, but also the must not miss diagnosis of ectopic pregnancy or let's say torted ovary, and like you're speaking about, any sort of scrotal pathology can radiate into lower quadrants as well. So that's sort of helpful right away to think outside of the box or outside of the peritoneum, or where thinking about these other organ systems here.
Yeah.
So that's I think super helpful off the bat. And I think with the history pieces there, you really would be able to whittle down your differential. And talking about nausea, vomiting, and stool consistencies for urgent issues, and of course vitals as relates to abdominal complaints, is super important. So why don't we lay our hands on the patient?
Hell yeah.
Yeah. So what in the lower quadrants, what are some points of interest where we may palpate?
Scrotal exam right off the bat.
Yeah, you can have a good old look at the scrotum.
Well, I think that we should maybe take a step back and review an abdominal exam, because we don't want to cut corners here. We're keen residents and medical students here. We're going to be going through the motions here. So as you mentioned, we'll take a look at the vital signs, and then always inspect the patient. So how does the patient look? Are they comfortable? Are they writhing around in pain? Are they trying to find a position that's more comfortable for them? Perhaps they're lying still, which would be a sign of peritonitis, where they don't want to do any sort of movement that will make the pain worse. Are there signs of malnourishment or muscle wasting? If we're considering something hepatobiliary, we could also look for signs of jaundice, things like that. Anyway, we look at the belly. So we're looking for scars, which, with our forgetful elderly patients, they might have forgotten a past surgery that we can ask about. So, we can take appendicitis off the differential if they've had an appendectomy before. We can look for striae, bruising. We can look at the contour of the abdomen. Is it protuberant? Is it scaphoid? Are there bulging flanks with ascites, which would be fluid in the abdomen? Is there organomegaly or some sort of masses? And then after inspection, we would auscultate. So this is a common